tonight. I am very pleased that Dr. Cappadona came to us and said, I'd like to talk about healthcare. Can I come here and do it? And we planned it, and now, without further ado, let's welcome Dr. John Cappadona, and so he'll have time to talk and enjoy the presentation.
Thank you. Thank you, Carol. Healthcare reform, why is it so expensive? Oh, I forgot to turn that on, don't I?
Yeah.
Sorry.
I forgot to remind you.
Can you hear me now? Oh, yes. Oh, my goodness. Good. Yeah, I tend to mumble. Why is healthcare so expensive? You have all thought about why is healthcare so expensive. You've all seen it go up and up and up and up. Often 25% every year or two in our premiums. That's not the whole story. It's not just our health insurance that's driving a healthcare expense so high, but that's what we're here to talk about tonight. I'm John Cappadona. I'm a primary care doctor. Been in practice 38 years, and I just I retired in July. I've been practicing most of my life in Simsbury, primary care. So I'm retired, so why am I doing this? A person who helped me put these slides together suggested, well, you're practicing the Hippocratic Oath, helping people do no harm. Yes, I suppose so. It's a little dramatic, but it does make the point that I'm not speaking for anyone but myself. Private citizen, I don't work for anyone, no agenda other than expressing my point of view. You'll hopefully be spurred to find out more and more about it, because we've all had this question: why is it so expensive? Well, the first reason, it's pretty obvious. We all get sick, so anything that's so expensive is going to always command a reasonably high price. We can't do without it. We're stuck with it. We must get it. So it's in demand. When we seek it, we usually get it, and high demand for anything usually ensures a high cost. But it wasn't always so. It wasn't always so expensive. As a matter of fact, and it wasn't always in such demand. As a matter of fact, prior to the 1930s, there was virtually no health insurance in this country. No health care insurance for a good reason. There wasn't much health care. The great advances in medicine that have taken place over the last 70 years were waiting to take place. And hospitals, for example, were a place where terminal care was largely provided. People rarely went to the doctor. You can ask. Your parents told you about that. The Depression made things a little bit worse, and nobody went to the doctor, and even fewer people went to the hospital than before. So the hospitals were in crisis. Baylor University Hospital in Texas thought of a good idea. The first time this was thought of, and that was providing health care insurance, hospital insurance, for pennies a month. And the idea really caught on because the public was ready for something. That was such a good idea that the government got in on the act, and they decided they would subsidize it. It would be tax deductible for employers to offer this. Then came World War II, and there were even fewer workers available in our industries. The industries were hurting for employees. That's where Rosie the Riveter came in. The men were largely off fighting the war. So there was a greater demand than ever for employees in industry. And private insurance became something of a perk. It was thought of then, why don't we offer health care as a way of attracting workers away from that company to our company, so that really caught on. And the government again subsidized that and made those deductible expenses for business, and it started to grow. It was a good idea. And then finally in the 1960s, the government decided to offer their own health insurance, Medicare and Medicaid. And there haven't been any real innovations since that time. We have the same kind of insurance that we did. What does a private insurance company do? If you'll give me 1 second, I'm afraid my slides got out of order. I'm going to take 1 second to put them back. This isn't exactly the set of slides. This is close, but not exactly. So I'm going to select the right set of slides. Here we go. 12:30:17. This should do it. Yeah. I think I like this set of slides better. Yeah. Let me back up a second, because this slide will show our agenda so that you can follow and know where I'm going with this. The agenda for tonight's talk will be our healthcare system isn't working, why is it so expensive? We'll tackle health insurance, what it is and what it does, and the history of health insurance. I started to get into that. Prescription drug prices, another big factor in healthcare's costs. Specialists versus primary care, the third big reason for healthcare being so expensive in our society. And finally, we'll look at the corporatization or business of medicine and see how it's done since it's been here for the last 70 plus years. Then we're going to talk about national health insurance, also called Medicare for all, single payer, it's all the same thing, national health insurance. This is a proposed solution to the problem that we're facing now of expense. We'll talk about what national health insurance is, how it'll affect healthcare, who will be the winners and losers in such a system, and my view of where healthcare belongs in our society. Finally, we'll talk about what you can do. We all get sick, it's always in demand, a high cost. There wasn't much health care at one time. Then in World War II, industry needed workers, and that's where we are now. Who pays for all of this? The term payer simply refers to the person who takes the risk for paying for your health care. That payer can be private or public. Private, Cigna, Anthem, Connecticut, etc. And public payer is the government, Medicare and Medicaid. All right, so they're paying for the cost. The costs consist of the cost of care plus administrative costs. The administrative costs consist of claims processing. Dr. Cappadona submits a bill. The insurance company will review it, see if I'm on the plan, see if I deserve that much, and et cetera, et cetera. That's claims processing. Administrative costs also consist of marketing, the advertisement of that product, and finally profit. Those are the administrative costs. So the total cost of care is the cost of the care itself plus those administrative costs. Private insurance administrative costs are about 10 to 25% of those total costs. 10 to 25% of the healthcare dollars that are spent by private insurance are not spent on healthcare but on administrative costs, claims processing, marketing, and profit. But this is 5 to 25 times higher than Medicare's 1 to 2%. 5 to 25 times higher. 1 to 2% versus 10 to 25%. Well, insurance companies are a big business. They must be doing something to account for that enormous difference. By the way, that enormous difference can translate to as much as $616 billion a year. That's the difference. It's a lot of money. What is the insurance industry to justify that? In a word, nothing. Not much. Not much important anyway. Fancy marketing brochures, occasional calls from the company nurse, free gym memberships. That's not health care. It's something, but it's not health care. We just did that. There we go. What about prescription drug prices? Well, the pharmaceutical industry is a very, very lucrative business, of course. pharmaceutical industry, along with the health insurance companies, are all members of the Fortune 500. These are very successful corporations. This is where the money is in our society, is in healthcare, and any company would be foolish not to tackle that market. Big Pharma is no exception. The pharmaceutical industry blames the insurance companies for the high cost of drugs. Why? Well, they have high costs to begin with. The drugs themselves are very expensive when they come on the market, but insurance companies negotiate that price down, way down, so that private insurers pay much, much less than sticker price for those drugs. But those reductions are not passed on to the consumers. They go towards that 10 to 25% administrative cost of private insurance companies. So Big Pharma says it's the insurance companies. However, Big Pharma puts an awfully high price on their drugs when they come out. Scandalously high. I mean, it just shocks everybody. As a consumer, we've seen prices go really right through the roof. Why are they so high to begin with? In Canada, the name brands aren't so expensive. Well, in Canada and in Europe and other developed countries with national health insurance, the price is negotiated down. But those prices are big to begin with, but then generics come on the market, and most of us who take medications are taking a generic. Generics are typically a lot cheaper than the brand name drugs. But Big Pharma came up with a way around that, and that is that they have either taken over those generics companies or made their own generics so that they're virtually competing with themselves. The stifling of competition in the drug industry keeps the prices way up. So why is the cost of an MRI or surgery so expensive? In France, an MRI costs about $300. In the US, private insurers pay about $1,200. Why the difference? Well, in our society, we've come to value specialized tests, specialized care, scans, radiology, procedures, and so on, much more than primary care. So this is what the market bears now. This is what the consumers want, and this is what insurers will pay. Often there isn't enough oversight. The attempts by insurance companies to provide oversight over the use of such expensive equipment is ineffective. We can all get around those things. We simply get Nancy here to get on the phone with the insurance company and get it approved. Of course, that takes a heck of a lot of time and effort, but we can get that done so that we learn what the criteria, what's the magic word for getting a scan approved when it's necessary. But the problem isn't usually that. The problem is too many scans. There are too many scans because this is now in demand. This is what our system craves. This is what we've come to respect, and we pay for that. A hip replacement in France costs about $10,000. Here it's $40,000. That's an enormous difference. The cost is driven way up by hospital administration. There are more hospital administrators than doctors and nurses that provide the care. Doctors and nurses make a pretty good living, but not compared to hospital administrators.
Are you open to questions during this?
After, please. We'll have a lot of time because this is only about a 30-minute presentation, and we will go through everybody's question. So this is what we value, this is what we want, and this is what we get. There are MRI scanners on every street corner. Everyone who's in the MRI business will seek to tap into that $3 billion a year healthcare industry. Again, a for-profit system is going to go for that. They'd be foolish not to. Why are there so many specialists? Are nurse practitioners and PAs replacing primary care doctors? Well, again, society values expensive specialists more than primary care doctors. In Europe and in Canada, primary care doctors make less than specialists, but not as much less. or I should say, the specialists don't earn what they do in this country. This is what we value. We place value on this, and this is what we pay for. Now, there's a downside to specialized care. I've been a primary care doctor, so I'm prejudiced, okay, in favor of primary care. But it's no secret that we no longer keep the same primary care doctor that we've had for years and years. Fewer and fewer medical school graduates are going into primary care. This leaves a void in primary care. The void is being filled by PAs and nurse practitioners, while very highly skilled people, and I don't think I've ever worked with a bad PA or nurse practitioner, the oversight of a doctor is capital, and every mid-level I've ever worked with appreciates working with a doctor and being schooled by the doctor and being shown. And it works both ways. I can't get along without my nurse practitioner in my office who's like this and gives me an answer like that, but she relies on my experience. And this is not the case in the walk-ins that have popped up. This is where primary care is really going. There's an urgent care center on every street corner now. I took a photo. I should have put it in these slides, but at Bishop's Corner, there's been a medical practice there. Hartford Healthcare has been in practice there for a number of years. Right next to it, an urgent care center is going up right away. I mean, again, that's a great location, and you got to want to get into that business because it's lucrative business. Are more doctors needed in West Hartford? No. But to get a piece of it, to offer some more convenience, to have drive-through, to be able to see a healthcare provider in CVS Pharmacy is now the rule. And you can get your primary care there. So that convenience, is always valued in our society. That convenience is being offered at your local CVS. So this is where primary care is going. We'll say more about nurse practitioners and PAs. I couldn't get along without them because there aren't enough primary care doctors. They fill a very important need, but supervision by doctors is necessary, and in most of the walk-in clinics, their supervision is lacking or totally absent. And the nurse practitioners don't like it either. All right. The corporatization of healthcare. How is it done for the last 70 years? Over $3 trillion a year is spent on healthcare in this country. This is one of the healthiest industries alive. Corporate America is wise to identify it as a source of enormous profit. And by that measure, they've done very, very well, and they have become exceedingly wealthy. But by healthcare outcomes, the U.S. has become second-rate at best. We rank 36th out of 191 countries in life expectancy, 39th in infant mortality. Of the 11 industrialized countries, the U.S. finished last in terms of access to care, equity, efficiency, and healthy lives. And this in a country with, by far, the most expensive health care on earth. All right. Now we'll talk about national health insurance, what I propose as a very logical solution to our dilemma. Again, it's Medicare for all, it's single payer, it's all the same thing. What's the main benefit of national health insurance? Very simply, what we're trying to do is to reduce health care costs by $616 billion a year, while providing truly comprehensive coverage for every American. Doctors, nursing homes, everything is covered. No co-pays, no deductibles. What a giveaway. There's a reason that it's deductible and co-pay free, by the way. Largely for the same reason that the police department and the fire insurance and your public schools are free of deductibles and co-pay. Okay, facts about it. It's not socialized medicine any more than Medicare is. It's Medicare for all, that's all. The doctors and the nursing homes and everybody else all remain private. Pharmaceutical industry all remain private. Most businesses would save a lot of money by being completely relieved of health care costs. On average, industry pays 8.5% of their payrolls in healthcare costs. 8.5%. That's an astronomical amount of money. What's proposed with national health insurance is to eliminate that entirely. So that 8.5% will go down to something like 3% in terms of tax, but a business is saving 5.5%. That's an enormous raise, and this is a very, very business-friendly proposition. In Canada, the three major auto manufacturers, Ford, Daimler, Chrysler, and GM, have all publicly endorsed national health insurance, which exists in their country, from a financial and business standpoint. This is a very, very business-friendly notion. Ford pays more for healthcare than it does for steel. GM had to be bailed out a number of years ago because of healthcare costs. They can't afford that. Not if they go up by 25% every couple of years. Another fact, with national health insurance, your health insurance doesn't depend on your job. This would give workers freedom to risk a job switch or to risk opening up a business without worrying about where their health insurance is going to come from. This is, again, this would be a boon to the American worker. How many people stay at their job just because of good benefits and can't move because of that? My son is in that position. Other people are in that position. I hear about it every day in the office. This is not this is no more a free government handout than current Medicare is. And this is an entrepreneurial boon. This encourages entrepreneurship and really putting our workforce to its maximum potential. Okay, myths about national health insurance. The government would dictate how doctors practice medicine. That's not true. In countries with national health insurance, doctors are rarely questioned. Whereas in the U.S., how many hours a week do we spend getting prior authorizations? How many practices must have a full-time staffer to get prior authorizations from insurance companies? Another myth, waits for care would be extremely long. We hear that all the time. Oh, well, in Canada they want a system like ours. Well, it's a very small part of Canada's healthcare problems. In countries with national health insurance, urgent care is given immediately. Routine care is given in a perfectly timely manner, follow-ups and so on. Elective and cosmetic surgery do require some waits, but even these could be significantly reduced with proper planning and scheduling. And to this I refer you to Improved Medicare for All. This is a bill currently before Congress. Another myth, people will overutilize the system. The only overutilization is going to take place, and there will be some, will come mainly from the currently uninsured. These are people who can't afford to go to the doctor, can't get insurance. They should go to the doctor. We all agree that. That's where the utilization will exist. The savings from national health insurance, that's $616 billion, will way more than compensate for any increased utilization. Well, the government can't afford it. Well, the reason that's not true is for a simple fact that the government is already paying for 60% of health care in this country. But how can that be, since 70% of insured people have private insurance? 60 and 70% doesn't add up. It's because the government subsidizes the private health insurance industry through what were previously simple governmental products, Medicare and Medicaid, are now being administered more and more and more by private insurance. Medicare Advantage, which I have, is an insurance policy administered through Connecticut. For that policy, Medicare pays Connecticut 15% more than they would pay for regular Medicare. Why is that? Because they have to get rid of, the Medicare trust fund will go broke at this current rate, and they have to shuttle that off. Connecticut has promised to reduce costs. They haven't reduced costs. Any reduction in costs is minuscule compared to the amount that insurance companies make off of privatized Medicare. The same thing for Medicaid, but more so. Virtually all Medicaid is now administered through private insurance. Again, that 10 to 25% of the healthcare dollar that goes through a private insurance company goes for administrative costs versus 1 to 2% for previous Medicare and Medicaid. Another way of saying it is that the private insurance industry spends only 75 to 90% of the healthcare dollar on healthcare versus 98 to 99% for Medicare. So if the government pays for everything, where would it get the money? Okay, here we go. 3% payroll tax on employers, but they're saving the 8.5%, so they're making out. They get 5.5% increase in their revenue. Very, very pro-business. An additional 5% income tax on the wealthiest 5%. In Connecticut, that means an adjusted gross income over $250,000 a year, typically on average $500,000 a year in income. But that excludes the first $140,000. It excludes unrealized capital gains, and it excludes real estate investment. For the top 1%, and that means an adjusted gross income in Connecticut over $660,000, or an average of $2.4 million a year, those people would pay an additional 10% income tax, but exempting the first $250,000, exempting capital gains and real estate. And everybody, even these wealthy guys, don't have to pay the $15,000 to $20,000 or more per year per family on health insurance premiums. And then, of course, eliminating abusive tax shelters with no legitimate business purpose. Most will win under national health insurance. 95% of families would pay less for truly comprehensive care than they currently pay for much skimpier coverage. 95%. In addition, employers will be relieved of their burden of providing health insurance. Federal and state governments are also employers. That's one of the bigger employers in this country. They are saving a pile with avoiding expensive private health insurance. And then finally, doctors and other providers will have time for their patients. The big loser, it's no secret, the health insurance industry, which hasn't demonstrated enough value to patients and society to be further bailed out by taxpayers. Savings from national health insurance, $616 billion a year, will more than pay for the retraining of the needed for the current administrative workforce in the private industry, the private insurance industry, while providing universal coverage of the entire population. I'm going to just mention a word about Obamacare. You may be wondering, where does that fit in? Obamacare was a law enacted in 2010 which sold insurance in marketplaces called exchanges. You bought your insurance in that exchange. You couldn't be excluded for pre-existing conditions. Your premium could not go up because of a prior a pre-existing condition. You had to be offered insurance. This offered insurability to an additional 20 to 30 million people. Good thing. But healthcare costs have skyrocketed since then. Why? Because more and more of the insurance is sold through private insurers. So again, that 10 to 25% goes up. They have more customers now through Obamacare. So that wasn't the solution to the healthcare crisis. It did insure a lot more people. But there's still 20 or 30 million who aren't insured in this country. Our economic system seems to work best with a balance between private enterprise and public service. The question is, in our society, should we treat healthcare as a commodity in the marketplace, or as the right of all citizens, like the police, the fire department, and public schools? If you want to do something about it, this is what I suggest you do. Find out more. Don't take my word for it. And there is a handout that will be given out which has my references and my sources. Check them out. Check out your own sources. Find out. I have searched and searched over the last 3 or 4 months for the insurance industry's rebuttal to all of this. And believe me, I shouldn't use that term. Some other people use that term. And that's not a good term to use here. Find out for yourself. Find out for yourself if the insurance industry can justify being in the business of health care. Talk with family and friends. See what they think. Call your Congress people. Call your senators. Tell them what you feel. Support candidates who are committed to reforming health care the way you think it ought to be reformed. But to do nothing shouldn't be an option. Write to the current. Tell them this is a big topic in our country, and I strongly suggest that in this upcoming election in 2018 that this will be a large topic, and you will see candidates addressing this. They might be telling selected facts, but they will be addressing it. So this is a topic that we can all understand. I don't think I was using particularly complex ideas here. It's a matter of dollars and cents and what we're getting for the dollars and cents. Everyone can understand this. Do something about it. I strongly suggest it's so important. These are the people who helped me put this together. I thank them because I didn't know how to do a presentation. I didn't know what a PowerPoint was, and these people helped me put this together. Very helpful. And let me thank Carol Lenig, if she's still in the room, our librarian, for allowing me the venue. Now we'll take questions. Thank you. Thank you. Will that go off now? There we go. Anybody have any questions? Yes.
I don't have a question, but I would just like to thank you very much for this presentation. This is something that I'm very passionately support. My husband and I are engaged with an organization called HOPE. It's Healthcare Over Profit for Everyone. And they're advocates, citizen advocates and lobbyists for national improved Medicare for all. They meet every other, twice every other week by teleconference. And if anyone's interested in it, I would strongly suggest that you look into that.
Hope,
because I couldn't agree with you more. I mean, we need to have major change in our healthcare. And, our legislators get lobbied aggressively by big pharma, by healthcare. Yeah. I think it's time for us as citizens to aggressively.
Our government officials are responsive. They're responsive to lobbyists, and they're responsive to you, the voters. They have to hear from you to hear how you feel. Otherwise, there's no impetus for change. Thank you. Hope.
Hope.
To find out about hope. Yes.
It's just my memory. What were we 11th in?
The 11 industrialized countries, we were 11th in terms of access to care, equity. In other words, everybody gets the same care. How good the care is, and something else, let's say. But it was important because of one thing. With all this money spent, we've got to be providing better care. But the outcomes don't support that at all. And the fact that some people and I've seen it again and again, a patient getting an MRI scan this month and getting it again the following month. They didn't ask for that MRI. Their oncologist may have suggested it to see if that inoperable cancer has gone yet a little bit more inoperably, and if there's been one or two more metastases or spread of the tumor to, I mean, these are things that could theoretically provide a little bit of information, but in terms of where we should spend our dollars, we need to look at that. We need to really look at what are we getting for this. That's money that's coming away from somebody else, and are we extending the life of that patient? Not appreciably, if at all. But we've all gotten into this. That's the standard of care. This is what they do. This is what is being done now. More is being done. Because you do enough, and you're going to find some usefulness of it. The thing is it worth it? Is it worth it? Yes.
It reminds me, I suggested that my book club read Atul Gawande's book, Being Mortal.
Oh, yeah. I've heard about it, but my wife read it. I didn't read it.
Very good. It talks about how we need to begin to accept that we're not going to live forever.
Yeah, again, this is where the primary care doctor should come in. He's supposed to be your coach. He knows you, first of all. He knows your wishes and desires. And he also knows the limitations. And your health can be best guided by somebody who knows you and cares about you. That relationship only comes with time. You don't get that at urgent care centers. You won't get that. I wish that if they're not going to mint more primary care doctors, then give me nurse practitioners and PAs, but let me supervise 4 or 5 of them in the office all day long. That's a perfectly feasible way to deliver excellent primary care. First of all, they're all conscientious. In my experience dealing with nurse practitioners and PAs, they're all conscientious. They're all anxious to do a good job. And to not miss stuff, they're going to order more tests and refer to specialists because they don't want to miss stuff unless they can come to me and say, where do we go with this? This is what I feel should be, this is where care should be going, directed by primary care. And, it's up to us. If we didn't... We're still subject to malpractice law. If we want to be cheap about health care dollars, it's not going to go into our pockets, but if that's what we're charged with doing, as we were charged in 1992 with managed care, we were all excited as primary care doctors. My wife called it the revenge of the nerds. The primary care doctors finally are going to be important in deciding how health care dollars will be spent. And we were all excited about this because we wanted to make that contribution. It was defeated, and it's not come up since. All right. This is what we get for ignoring that, though. Any more questions? Mr. Goldie.
Yeah. Why are most people reluctant to have the government pay the government, just like your Social Security?
Our system is not the same as Europe or Canada. We are much more private industry oriented, and this will go under the topic of how much do we want the government involved in our lives? And the answer in our country is we want it involved to a certain extent, but not too much. That's America.
Yeah.
We're supposed to be balanced.
You don't trust the government. You trust them with your Social Security. You'd rather trust private insurance.
Well, and there's a certain logic. Yeah. There's a certain logic to this, but part of that is what we feel made America great, and it's true. Private industry thrives in this country, but we also have a health care system that it doesn't work for health insurance. It just doesn't. It doesn't because it's supposed to be for everybody. So that's supposed to be a public good. It's not supposed to be a private good. It's not supposed to be a commodity. If you really want everybody to have it equally, do we want that? That's the question. The society has to answer, and we'll answer it at the ballot box. Yes.
It's like you always said, people would say, well, I don't want socialized medicine, but don't touch my Medicare.
Yeah, right. Keep the government out of my Medicare. I've heard that.
Socialism.
Yeah, we're scared of that, and And to have unquestioning faith in your government is not healthy either. Everybody has to have checks and balances. But in this case, I'm proposing that health care shouldn't be on the marketplace. It just hasn't worked. And they've had a long time to make it work. They've had a long time. And they're trying to manage care, but they don't do it well either. And I've spoken with people in the insurance industry very recently. Very knowledgeable guy who I've known since he was a kid. And he's a little bit of a big shot. And we had a very frank discussion about health care and where health care belongs. And even he will admit to some ambivalence about how the system is operating. Yes.
Just a little help in the mechanics, because it's something I don't have much knowledge. I'm virtually a newbie, even though
I was 3 months ago too, before I started this.
I'm 3 months behind.
Okay.
I have, my husband and I have Medicare Advantage, but I know that in regular Medicare and Medicare Advantage, some exceptions in Medicare Advantage, you pay a monthly premium.
Or not. Some of them are free of premium. Yeah.
Yeah, but you pay a price there.
Yeah.
You know. Anyway, in an NIH environment, my impression is
National Health Insurance, NHI. Yeah.
okay.
Right. Okay.
You don't pay a premium. You pay.
You're paying taxes. This is coming out of our taxes.
And
Coming
so
out of our
it becomes
taxes.
part of a federal tax. Some kind of a federal tax.
That's a federal tax I was referring to. Those tax increases.
And so then when you can go, you go to your health provider.
And you got a Medicare card, like everybody over 65 gets. You got a Medicare card, and that's what you present. Under improved Medicare for all, and this is worth looking at just a little bit. Don't read through that. But improved Medicare for all, that's a bill before Congress. Both houses of Congress have this bill pending. It will never get to the floor with the balance of power the way it is now. But maybe after the next election it will. That will then be what you pay. Nothing. You put this down, you've paid. You're paying your taxes. And these are credible numbers.
Additional tests, though, beyond basic care, that's still part of the...
Basic care should include your surgery completely, your nursing home stay after that completely, everything. Now in Canada, it's funny, Canada does not cover drugs. Their Medicare does not cover drugs. Their drug prices are a lot lower than ours, though. But they must pay for those, or they will take out insurance for those. But still, their prices are less. Why? The government negotiates those prices down. And although private insurance negotiates those prices down from the pharmaceutical company, that goes toward the health insurance company's bottom line, and not our bottom line. There's a case to be made, by the way, for private insurance companies, for private pharmaceutical industry. The great advances that have taken place in medicine, in the pharmaceutical industry, are wonders. They're total wonders. And the question comes up, would we be stifling that innovation with negotiated prices, with the government being able to negotiate down those prices? If they're not going to make their money back, well, if they're not going to make as much money, I would say, will that disincentivize the pharmaceutical industry? And the answer is, if we look in other countries with their own pharmaceutical companies, it hasn't seemed to there. In other words, they can make a profit. We're talking about the size of profits, though. Yes?
I have to disappoint you, but most of the high cost of the drugs is carried by us. The initial high cost development is done in universities. A drug company may choose or may not to adopt the drug for before production for the health trials.
Yeah.
That's when it gets transferred to the private industry. But
those are very, very expensive
yes,
trials too. They do spend a lot.
They use that excuse to justify the high cost. However, to your point, would innovation be stifled? No. Universities would still do what they do.
I always thought that This bothered me. A few weeks ago, I went back and I said, when I was in medical school, way back in the 70s, wasn't all the research being done by the universities that we were attending? And it still is, but it's always, and it always has been, in conjunction with the pharmaceutical industry. And I'm talking about things as varied as vaccines. Certainly chemotherapeutic agents. The universities cannot afford to do that. They have the eggheads, they have the doctors who come up with theories, and they're not private employees of the industry. But in order to move beyond an idea, big pharma pays a lot of money, and we get quite a bit of benefit from it. But it doesn't have to be that high a profit that is made.
I will continue to argue with you because big pharma got the concession that they will not accept foreign trials. They have to do it themselves. So
well, that's the FDA.
that is a concession that Ronald Reagan made back in late 70s in return for the orphan drug something or another, which also included the footnote
It's interesting.
that the government should not
Interesting.
negotiate quantity discount.
Well, another place where negotiation is prohibited is in Medicare Part D. Our medications that we get that are paid for, it is by law prohibited for the government to negotiate Medicare drug prices. It's prohibited by law. That's how that law was able to pass. Again, the lobbies by the pharmaceutical industry are strong. And for a Republican administration to lobby for a benefit like that, there had to be a good payment, tit for tat, and there was. No negotiation of drug prices for Medicare. Yes?
Is there a model out there of a plan that would be like the national health insurance sort of thing that included drugs?
The question was, and I'm sorry I didn't repeat these questions, is there a model for national health insurance that we can go by? And yes, there are several models. None of them are perfect, and none of them are the United States, by the way. We're going to have to adopt our own that works for us, but we can take from the experience of those countries. Since World War II, there's been national health insurance in most of the developed world, other than the United States. That's a long time, so that we can look at their successes, and we can look at their failures. That story of you got to wait for a hip replacement in Canada, so they come to the U.S. That sometimes does happen. However, that's an elective procedure, and that's being done at the expense of children being able to be vaccinated, so that there's going to be trade-offs. And we have to decide as a society. Who's going to decide what's covered, by the way? Well, Medicare already has a set of criteria over what's covered, and it's pretty fair. I've been working in Medicare for 38 years, or been seeing Medicare patients for all that time. And those are pretty fair restrictions that are made. Some of them are arbitrary and silly, but most of them make sense, and it's usually, almost always, based on what's called evidence-based medicine. You show me the study that shows that this is a benefit, and I'll cover it. And that's how it should be. I mean, you want health professionals making these decisions, don't we? I mean, who else? Yes?
I was just curious, who would pay all the doctors and the specialists? Does the government pay?
Yes,
So
everybody. Like they do for Medicare, like Medicare does now.
So you would, like the specialists, I mean, you wouldn't make as much money as physicians like they do now. And that
if you had only Medicare patients, you would make less money than if you had private insurers. That's true. For years, we squawked about having too many Medicare patients because we were paid less. Not a heck of a lot less, but less.
But you'd get paid a lot
you get
less
paid,
if you had all national health insurance.
Well, frankly,
I don't
what I'm
really care.
proposing, and as a primary care doctor, what I'm suggesting is that in the health field, our specialists make much, much more than they do in other countries. But that's a supply and demand thing. We demand a lot of specialists. We demand a lot of MRIs in this country. Is it justified? Is it good medicine? The answer is no. In many cases it is not. It's convenience, it's what you read in the New York Times, but it's not good medical care necessarily. You want a medical person making the decision and knowing that there's a budget. There's a budget that you have to keep in mind, and it's not unlimited. That's managed care. Yes?
I'd like to say to everybody in the room that to just do what you did, call everybody up and really move forward with this. You know what really worries me, that Bob and I have been here for over 50 years and love this country. We're still here, as you can tell. What upsets me, here we are with going through another government, another healthcare crisis. In Scotland, where we're from, you're insured from birth to death with national health. It's not a tax. I mean, it's called a tax here, but it's a contribution. Here we have all those children that the government won't even cover. My heart breaks. I say a prayer every night. You know, it just, something's got to be done. Somebody's got to, I'm not the one doing it, but somebody's got to speak for the children. You start with the children. The only industrial country in the world that doesn't take care of their children or their elderly. So I would really like to follow what John's doing, go forward with it, and we'll all be behind you.
You started. You started, Isabella. Yes.
Can I ask two questions? I'm sorry.
Who else had a question here? We're going to come back to you then. Somebody who didn't ask yet. Maybe they changed their mind. Go ahead. You got the floor.
Can I ask two questions? One is, I thought the question was good in terms of healthcare providers and physician salaries, but if there was National Approved Medicare for All, I mean, I feel sorry for healthcare providers, and you've got to have a lot of administrative costs to deal with all these different insurance companies with all these different rules and regulations and back offices. I would think that there would be an administrative savings as well. Wouldn't there be if everyone...
616 billion. That's what would be saving. But the answer is an offshoot to that too, and that is that why doctors, the rest of us, like me for the last 3 years, left my private practice and allowed UConn to take over my practice. I knew I was going to retire in a matter of years, and the regulations got too much. Let them worry about it, and let them pay me a salary. And more young doctors are doing it this way. Okay, you got to do it because of the paperwork, the prior authorizations, the regulations, the electronic medical record. Don't get me started on that.
Well, and my other question, and this is a pet peeve of mine, but do you agree? Do you think that pharmaceuticals should be able to be advertised on television?
You know, I'm pro and con. I get a lot of phone calls about it, and then I have to dispel notions, but it does make people aware. I'm always in favor of people having more knowledge than less knowledge. It shouldn't be a secret. It is what it is. It is what it is. You know, if we were paying more, if that were driving up our healthcare costs, and it is, because of course they are paying for that commercial space, and that's their bottom line, so that the prices got to go up a little bit. So there's that. But it's with us. It's with us, and some people, you know, some people learn stuff, and then you listen to all the side effects there. 10 minutes of side effects. I'm not taking that stuff.
Yeah, I know, but in real low voice.
Yeah, fast, right. Anything else? Leanne.
I just wanted to bring forth, you're talking about prior authorization, and I think all of us have probably faced problems in this area, and I personally have had 4 physicians recommend the same scan, and Anthem continuously has denied. I'm lucky enough, and I hope everybody is aware of the Office of the Healthcare Advocate of Connecticut. And I'm lucky enough that a very good friend of mine is a lawyer there. And he's so excited that we have just gotten the 4th denial, because now he says I'm going for the jugular. Because he's like, I'm going in there and say, you're going to tell me that you, who hasn't practiced medicine in years and years and years, and you've sat behind a desk, are going to fight with the physicians that are treating. So if you haven't heard about him, it's the healthcare.
What is he called? The ombudsman? Oh, the advocate, healthcare advocate.
Of Connecticut.
So it's a state person. Yeah.
It's downtown Hartford. My friend's name is Damien Fontanella.
Looks like he's going to get a lot of business from this.
He's really through different things. You know, my daughter's healthcare situations, that he has done battles for us, and I mean, he goes for it. And so, if you're having problems, I just want you to know that that's available.
Healthcare advocate. That's a good point. Yes, ma'am.
Just a quick question. Somebody touched on this, a consolidation of the healthcare industry that we all see. And in terms of how big of a lobby and everything that's going to be now, in terms of going to be, you have the pharmaceutical industry, you have the health insurance companies, and now you're going to have these huge consolidated medical, industrial, UConns. And
CVS/Aetna.
And I just was wondering what you thought of.
It's business. It's business. You want business, you're going to get business. We want business, but I'm saying not in the healthcare industry.
But how are you going to struggle, we, the people?
At the ballot box.
Against them.
Against them.
At the ballot box.
$600 billion that they're not going to make. They're not going to be happy.
Right. Well, they're
You think? I'll tell you, that's going to be tough, but bigger, When Medicare first came out in '64, I wasn't born yet, but actually I was. But I remember when it came out, the arguments against socialized medicine, the lobby, the AMA tore it to shreds. Everybody, they're never going to give it up. And they gave it up. Why? Because at the ballot box, it was a popular notion. This is a popular notion. This health care for all, Medicare for all, national health insurance is very popular. Poll after poll shows it. Yeah, I'll pay a little bit more in taxes, or most of us, of course, we're not in that 5% or 1%. So we're not talking about, this is a progressive tax. It doesn't mean socialist, really, but there are people who will say that. Look, yeah, it's progressive, meaning you're richer and you're going to pay a bit more for those who don't have insurance. That's true. That's true, but we pay. That's our current tax is also progressive. It's not a flat tax. Our current taxes are, you make more, you're in a higher bracket, and you're paying for more services for underserved populations because you got it. You got it to spend, and you're still rich after your taxes. I guess that's the idea behind a progressive tax, and this is what's being proposed for this. No different.
No, it's just different from what Bernie Sanders has. I mean,
no, that's his bill. That's his bill in the Senate. Improved Medicare for all. Yeah, and Conyers in the House. That was his bill for the last 5 or 6 years. He was the first guy to recognize the importance of it. And those are the two bills. Whether they get to the floor or not depends on who's the speaker. And that's what we can do something about, yes.
But then what causes it not to get to the floor? Is it all the lobbying?
The Speaker of the House will determine what gets talked about, or what even gets into a committee.
But if the general consensus in the country, or a growing consensus...
The general consensus has to translate into elected representatives being in favor of that point of view. It's the only way. Congress won't act on polls. They will act on the membership of Congress. And 2018 is an opportunity to voice your concern.
Is this going to be on the ballot box? I mean, how will that be?
Well, in Connecticut, we have people declaring their candidacy for governor. At least 2 of them are already on record as saying they're for national health insurance. And they're saying that because they think they can get elected because of it, not just from the goodness of their hearts. They're politicians, and they perhaps they believe in it, but they also believe that their constituency believes in it. And if those people will elect them, that's how this can happen. If it can happen for the governor of Connecticut, it can happen for the representatives. I believe, and I can tell you, I've spoken to 2 of our both senators. One is very much in favor of national health insurance, and the other is still on the fence.
Why?
Which is which?
Well, it's politics.
Esty is where?
No, she's a representative.
She's a representative, and I don't know where she stands. But rather than identify those people, find out. Find out where they're on. Find out about Blumenthal. And I'll tell you, I think the smart money in this election is going to be on national health insurance because I think it's that popular. The polls seem to indicate that it's that popular. But you ask about Murphy and Blumenthal and where they say 2 seconds on Google and you'll find that out. And I'm trying to make a difference in another state because all of our congressional representatives will be in favor of national health insurance in one form or another. They won't be against. But the closest district to us that's on the fence, that's swingable, is in New York State, and I'm trying to persuade voters there. If this is important to you, then hold your elected representatives accountable. Yes.
Is this something that can be done on a state-by-state basis?
Very good point. It's being tried. It was tried in California and it was shot down. It was tried in Vermont and it was shot down. The legislatures would not pass those measures. It would be very difficult to do in a small state. For insurance to work, you have to have a lot of members. You have to have a lot of people paying into it. That's the only way insurance works. It's there for you when you need it, but everybody pays into it. And the small states, it's going to be tough. New York State might. They have something that are really trying. Again, their legislature, one body of the legislature, won't permit that to come to the floor for now. That's why the ballot box is so important.
What about the 1%?
I'm sorry?
California's a huge.
California's huge. If California... If New York State can swing this, and one of our governor candidates is in favor of this, if he were, if the state houses in Connecticut were in favor, there could be a coalition of New York and Connecticut, and probably Massachusetts, and then you could have a real big pool of lives that could make the Northeast, the New England health insurance plan work. You have to think about those things. Maybe it's not going to be every state, but you ask any resident, any recipient of Medicare in any state, red or blue, if they would trade their Medicare for having to pay premiums, and they would say, "What are you, crazy?" Medicare is a deal. It's a great deal. And it should be everybody's deal. Why do you have to be 65 or disabled to have Medicare? That's how I look at it. I mean, that's a personal choice that society has to make. That each person has to see how they feel about it. Yes.
Is there any way to influence the cost of the actual product?
Yes. Yes. Pay doctors less. No, I'm only kidding. Not me, anyway. Pay me the same or a little more. But, yeah, you don't need this many MRIs. You drive along Farmington Avenue near the health center, And there's nothing, it's a city of healthcare there. How many doctors need to be there? How many MRI scans need to be there? Because this is where the money is. And that's why Gimbel's and Macy's are across the street from each other, because that's where the shoppers are. And this is the same thing, cashing in on a market.
Do you negotiate MRIs?
They're not being negotiated. And it was hard to find out why, but it's not, mainly because we value them. We value them. The patients value them. Say, I want an MRI. Or my oncologist says, now we're going to get another MRI. And there'll be instances where that MRI should be done and is excluded. But there are many cases where the MRI is done, and don't do that now. Don't do that now. What is that going to answer for you? This is a medical decision, and it should not be an insurance company's decision.
What I'm actually asking is about the cost of the actual product.
It hasn't gone down, has it? Except it's gone down in Japan and in France. It's $300, and here it's $1,200.
How do we influence that?
But the reason is the government negotiates the price down. It says no, that's too much. That's excessive. This is what's reasonable. That's getting the government involved in things that not everybody wants them involved in. But somebody's got to do it, and if you keep it a commodity in the marketplace, we see where that goes. Yes?
In the case of MRI and other expensive equipment like this, instead of buying it, they lease it. So that's a fixed monthly cost, and divided by the expected use, that's how much they charge for it. Mm-hmm. If they can squeeze one extra, that's clean profit.
Yeah.
And this is what keeps the cost
high.
The
profit motive, Is profit a bad thing? No, it's a big stimulus, isn't it? It is.
Healthcare happens.
But in healthcare, it doesn't work well. There's too many gaps. There's too many problems, and it just costs more and more. Every place else in our economic system, increased competition lowers the price. Not in healthcare. Not in healthcare, because that's special. And that we invent a new drug every day. By the way, another thing about the pharmaceutical industry, it's a wonderful thing. But did we really need 7 beta blockers or 12 ACE inhibitors? These are Me Too drugs, and it's it's getting a piece of that market. Shouldn't the FDA also be in the position of I'm going beyond the scope of my talk, but saying there's enough of that. Work on something that's needed now, because we're good for now. We don't need more and more research to add another carbon atom to this molecule so that you can sell it as a different drug. The worst thing I heard was this. Colchicine is a drug that's used for gout. You have a hot toe, real inflamed. You give colchicine, it works. It's been used for 1,000 years, colchicine. It comes from the bark of something. God knows what it comes from. And it's always been used. It costs pennies a month, those pills. All of a sudden, a smart guy in a pharmaceutical industry said, hey, guess what? There's no research. Our FDA says that there's got to be recent studies showing the efficacy of this drug. There wasn't any. The drug has been around forever. So that all of generic colchicine was banned from the market. And this guy came up with a few studies for his drug that he called Colchris. And Colchris was the only drug. And guess what? It was very expensive. And that's a scandal. Why would the FDA allow such a thing to happen?
That's my question.
Yeah. It shouldn't have. But that's the law. That was the law at the time. So these laws can be changed, though. And, but it's, laws are never going to be perfect, and they're never going to be all-reaching. They're going to be as good as they are at the time. But where there's a profit, the problem here was the profit motive for that guy to sell something new and call it something different because of a piece of paper that he had. That wouldn't have happened without that profit motive.
Sugar.
In medicine. Wow. All right. For anybody who's really interested, I will have a complete bibliography, but two things that will be on this handout. And please, everybody, take a handout because it was such a good talk. You know, you're not going to remember everything, so. But I want to leave you with one bit of information, and that is that I got interested in, I've been interested in this for a long time, but there's this publication. If you don't want to have to go crazy looking for sources, this is called Common Sense About Healthcare in America. It's written by this guy. He's a great guy, John Guyman, MD. He's a primary care doctor. He's got to be in his 80s. He's still practicing. He puts me to shame. And he came out with this pamphlet. What is it? 30 pages and 25 pages. And he's done the research. And this, it looks like Thomas Paine's Common Sense, doesn't it? Well, it's not for nothing. But it's good. And it's in the bibliography in the handout. At the end, you'll find it. That's a great publication. And if that's not enough for you to read, he wrote a big one. And it's called Crisis in U.S. Healthcare, Corporate Power versus Common Good. It sounds a lot like what I've been talking about. But you know what's interesting about this? He talks about medicine the way it was and how it's become. And it's a great story from a very committed doctor. So I recommend them both to you. And thank you for coming out tonight. No snow. Yes, thank you. Thank you.
Funding for Simsbury Community Television is provided in part by contributions from viewers like you. Thank you.